Hi everybody, how are you doing? Are you at the home? I believe that you are taking good care of yourself and your family members. Okay, today's class is about malaria. So, when you hear a word malaria, we are learning about malaria since from the beginning of our plus two or intermediate, isn't it? We learn about the life cycle of the malaria since very childhood, isn't it? So let us uh, review again what do we know about the malaria and what are the things we have to learn about the malaria. Human malaria can be caused by 4 species of the Plasmodium. When I mentioned human malaria, it will give, say, uh, a doubt that is there any animal malaria? Yes, it do occurs. And these malaria is most common in Africa countries. So it is caused by protozoan Plasmodium. So there are 4 species of the Plasmodium, and these are Plasmodium falciparum, Plasmodium vivax, Plasmodium vivae, and Plasmodium malariae. So the diseases are called falciparum malaria, vivax malaria, and malaria ovae, malaria malariae. Okay, of all these things, in our country we see the 2 species most commonly, that is vivax and falciparum. So this Plasmodium vivax is characterized by a recurrence of the malaria. That means once the patient gets the fever, malarial fever, and they are more prone for getting the recurrence after 2 to 3 weeks. And we will know why that happens. And falciparum malaria is more dangerous one because it can cause fatal cerebral malaria. So we have to keep in mind these 2 species most importantly, and we have to remember the other species also, the oval and malaria. Coming to the epidemiology of malaria, it is transmitted by the bite of female Anopheles mosquitoes. We all know about this female Anopheles mosquito. Whenever you remember the malaria fever, we remember about the mosquito bites. And which mosquito? Female Anopheles mosquito. And not only through the bite of the Anopheles mosquitoes, the malaria can also be transmitted in contaminated blood transfusions. Suppose if a patient suffering with a malarial fever gives the blood for a donation, if it contains the malarial parasites, and if any patient receives that blood, they also can develop malarial fever. And drug users sharing the same needles are also can be prone for getting the malaria. The disease occurs in endemic and epidemic form throughout the tropics and subtropics. So the tropical countries like India and Africa and whatever the countries which are lying nearer to the equator, these are the areas which are more prone for developing the malarial fever. However, malaria is very uncommon in high altitudes. At 2000 meters above the sea level, the mosquitoes are less frequent and the disease transmission is very, very rare. Coming to the parasitology of the disease, it has two life cycles. One life cycle in female Anopheline mosquito, that is malarial parasite develops within the Anopheline mosquito, and second is it is the life cycle within the human being. That means it undergoes few changes before getting infects the patient. So what are the stages or steps in the female life cycle in female Anopheline mosquito? So whenever the female mosquito becomes infected after taking a blood meal containing the gametocytes. These are the sexual form of the malarial parasite. It can be oval or vivax or falciparum malaria. So the female Anopheles mosquito gets infected with the gametocytes whenever it takes the blood meal from a patient suffering with the malaria. And these gametocytes becomes sporozoites, and these sporozoites infects the next human being. These infective sporozoites migrates to the insect or mosquito's salivary glands. So what we have to remember is the life cycle of the malarial parasite begins with gametocyte stage within the female Anopheline mosquito. This happens when it takes the blood when it bites the patient, it sucks the blood. So the infected person who are having the gametocytes in their blood infects the mosquito, and within the mosquito these gametocytes undergoes different stages and forms sporozoites. These sporozoites migrates to the salivary glands of the mosquito. Okay, and these sporozoites are infective to the next person or next human being whenever it bites that person. Life cycle in human being. When the infected mosquito bites a human, the sporozoites are inoculated. So I'm not going into the details how the process of what are the processes that takes place when the mosquito bites. One, it sucks the blood, and second, it inoculates the saliva which contains the sporozoites. These two things happens when a mosquito bites. We have to keep that in mind. So whenever the sporozoites enters into the human being, some of the sporozoites are destroyed by the immune cells. The remaining sporozoites are taken up by the liver. Within the liver cell, there is a stage called pre-erythrocytic sporogamy. In this stage, the sporozoites undergoes different stages and becomes merozoites. So within the liver cell, from the sporozoites, merozoites are formed. So this is pre-erythrocytic sporogamy. And some of the sporozoites as hypnozoites. This happens especially in vivax malaria and oval malaria. So in falciparum malaria, there won't be any hypnozoites. Only in vivax and oval malaria, these sporozoites, some of the sporozoites within the liver cell becomes the hypnozoites and stays in the liver for quite a long period. And from these hypnozoites, again sporozoites are formed which infects the human being second time. That is the recurrence. This we have to keep in mind. What happened when the liver cell containing merozoites ruptures. So the infected liver cell ruptures and releases merozoites into the blood. This merozoites enters the red blood cells and they multiply. This stage is called erythrocytic sporogamy. And this erythrocytic sporogamy occurs within the red blood cells. And in red blood cells, the merozoites becomes trophozoites, and these trophozoites become schizoids, and schizoids becomes merozoites or neuromerozoites, new merozoites again. And this takes place 48 to 72 hours time. So the infected RBC ruptures and releases merozoites, which are taken up by healthy RBCs, and the cycle is repeated. A few merozoites in the RBC becomes gametocytes and enters the mosquito when it takes blood meal from the infected person, and the life cycle again starts in the mosquito. This is about the life cycle of the malarial parasite within the mosquito and within the human being. We have to keep in mind the gametocytes enters into the mosquito, and the mosquito, within the mosquito, through the salivary glands and through the saliva, the sporozoites are released into the human being, and these sporozoites are taken up by the liver cell, and sporozoites becomes merozoites, and these merozoites enters the RBCs, and within the RBCs it goes into several stages and becomes new merozoites. And when RBC ruptures, it releases the merozoites into the blood circulation, and these merozoites are taken up by the healthy RBCs, and again they produces more number of merozoites. As more number of the merozoites or infected material is getting released into the blood, it causes certain changes and is responsible for the manifestation of the disease. The pathogenesis. The pathology of malaria is related to three factors. One is cytokine release. This cytokine release is responsible for the inflammatory processes like fever and loss of appetite, malaise, etc. Impaired microcirculation. So these damaged or infected RBCs, they block the capillaries and impairs the circulation to the tissues, and it causes multi-organ damage. So it can affect the kidneys, it can affect the gastrointestinal tract, it can affect the brain, like that. And third factor is anemia. So these patients develop manifestations due to anemia. So the anemia is result of rupture of the RBCs, and usually we see it as a hemolytic anemia. Okay. Coming to the clinical features. The normal incubation period for malaria is 10 to 21 days. The most common symptom is fever, and often the fever will be severe, and sometimes it is 41 degrees Celsius. The characteristic of fever is it is usually associated with chills and rigors and drenching sweats or severe sweats. The other symptoms are headache, malaise, vomiting and diarrhea. So these are the common clinical features for malaria. Plasmodium vivax and Plasmodium vervale causes mild disease and spontaneous recovery occurs within 2 to 6 weeks. Hypnozoites in the liver can cause recurrence, as we have learned earlier. Plasmodium malariae causes mild disease. It has a more chronic course. And Plasmodium falciparum malaria causes severe disease. We will see now what are all the characteristic features of these disease manifestations. Okay, of all these types, falciparum malariae is a severe one. Here, patients can deteriorate rapidly. Especially in children, the disease progresses from health to coma. That is, the patient can get a fever and over a period of within hours, the patient lands into coma and succumbs to death. And falciparum malaria can manifest as a cerebral malaria. How will be the presentation? The patient will have high grade fever, and fever is common in all types of these malaria. Okay, and especially the silent features of cerebral malaria are they'll have diminished consciousness, confusion, convulsions, coma. Patient may later may die because of the cerebral malaria. So, if you are asked to write about the cerebral malaria as a short notes, you have to write it is caused by falciparum malaria. And the incubation period is 10 to 21 days. But once the disease starts, the patient deteriorates very rapidly and it is characterized by diminished consciousness, confusion, convulsions, coma and death. Convulsions are nothing but seizures. So high grade fever, seizures and coma, we have to suspect cerebral malaria, and especially in children we have to give the first thought of cerebral malaria. Okay. What is called black water fever? Black water fever is again caused by falciparum malaria. It is due to widespread intravascular hemolysis, that is infected RBCs. The large number of RBCs, when they get ruptured, it releases the hemoglobin into the circulation, and this hemoglobin through the kidneys it passes into the urine. So we call that as a hemoglobinuria, hemoglobin within the urine, and this hemoglobin gives a dark color to the urine. That is called black water fever. So the black water fever is caused by falciparum malaria. It occurs due to intravascular hemolysis and presence of hemoglobin within the urine. Other features of falciparum malaria are, as I have mentioned, the malaria manifests as another presenting feature is multi-organ damage due to obstruction to the microcirculation. And if there is a kidney involvement, these patients may develop acute tubular necrosis and uremia, that is renal failure. And what are the blood manifestations? Patient may develop severe anemia and disseminated intravascular coagulation. What are the respiratory manifestations of falciparum malaria? It can cause acute respiratory distress syndrome. The patient presents with high fever, cough, breathlessness, and this breathlessness becomes so severe that the patient may land into ARDS or acute respiratory distress syndrome. What are the metabolic manifestations of falciparum malaria? Patient may develop hypoglycemia and metabolic acidosis. Gastrointestinal manifestations are diarrhea and jaundice. Other manifestations are hypotensive shock and hyperpyrexia. So these are the different manifestations of falciparum malaria. So falciparum malaria, things we have to keep in mind is causes cerebral malaria, causes black water fever, and it involves the kidney, it involves the blood, it involves the respiratory tract, it can cause the metabolic changes, and also it can cause gastrointestinal manifestations. Well, coming to the diagnosis, identifying the parasites on gene-sustained thick or thin blood film is the important drug of, the choice of investigation. And there is a test called quantitative Buffy coat analysis or QBC test, which also identifies the parasites. Well, when you diagnose a patient with malaria, you will confirm the diagnosis by doing the peripheral smear test, and we have to manage the patient. So the management includes mostly the medical treatment. The drug of choice for malaria is chloroquine. How much chloroquine you have to use? The dosage is 600 milligrams start, followed by 300 milligrams 6 hours later, and 300 milligrams 24 hours later, that is on the second day, and 300 milligrams on the next 24 hours, that is the third day. The first day we have to give 600 milligrams start, and following the 6 hours period, next 6 hours we have to give 300 milligrams tablet. And the second day we use 300 milligrams, and the third day is 300 milligrams. This is the course for malaria treatment. Chloroquine resistant falciparum malaria or vivax malaria. So nowadays patients are developing chloroquine resistance. So we have to use, if the patient is not responding after the usage of chloroquine, but the disease is confirmed with QBC test or peripheral smear test, we have to consider the other medications. Those are Fansidar is the drug which contains pyrimethamine and sulfadoxine. And Fansidar can be given as a single dose of 3 tablets. The other drugs are quinine 600 milligrams 3 times daily for 7 days, plus tetracycline or doxycycline 500 milligrams 4 times daily for 7 days. This is the treatment regimen for the treatment of malaria. Well, there are other antimalarial drugs which are in use. Those are mefloquine 20 milligrams per kg in 2 doses 8 hours apart. Malaron is also indicated. We give 4 tablets daily for 3 days. And the newer antimalarial drugs are artemisinin derivatives, which is artesunate 2.4 milligrams stat, then 1.2 milligrams per kg body weight. These are the drugs which are used in the treatment of the malaria. Well, treatment of severe falciparum malaria in adults. What are the, if like cerebral malaria, if we are suspecting a patient, how we should use chloroquine sensitive cases. So the malaria is 2 types: chloroquine sensitive malaria and chloroquine resistant malaria. So in case of chloroquine sensitive malaria, we have to use chloroquine tablet 10 milligrams per kg body weight, intravenous infusion for 8 hours, followed by 15 milligrams per kg over 24 hours. In case of chloroquine resistant cases, quinine salt 20 milligrams per kg infusion over 4 hours, followed by 10 milligrams per kg over 4 hours for every 8 hours. If the quinine is not available, we can also use artesunate in place of that. How much artesunate we use? 2.4 milligrams per kg intravenously, then 1.2 milligrams per kg body weight. This is the treatment of severe falciparum malaria. The main drugs, but other things, if the patient is in shock, we have to give intravenous fluids. The patient is having high fever, we have to give antipyretics. The patient is developing vomitings, we have to give metoclopramide or other drugs. Okay, so apart from the general measures and management of the patients, these are the specific drugs for using in the malaria cases. Well, malaria prophylaxis for adult travelers. So malaria occurs in endemic and epidemic forms. There are regions, say for example in India, Odisha is the place where the malaria is very prevalent, and whenever people are traveling to an area where malaria is an endemic region, then they can take some precautions. And these areas are identified as chloroquine resistant areas and no chloroquine resistant areas or chloroquine sensitive areas. So chloroquine resistant areas, we have to use mefloquine 250 milligrams weekly, and in chloroquine sensitive areas we can use chloroquine 300 milligrams weekly. For how long? As long as the traveler or a person is staying in that area, they has to take these tablets every weekly, and once they come out of the endemic area, this regimen has to be followed for at least 2 to 4 weeks, because the incubation period of malaria is 10 to 21 days. So have to continue this prophylactic treatment for up to 3 weeks. And other measures are using the mosquito repellents, using mosquito nets, and remember, there is no vaccine for malaria. In summary, malaria is caused by Plasmodium species of Protozoa. There are 4 species: Vivax, Bovale, Falciparum and Malaria. It is transmitted by female Anopheles mosquito. The life cycle in mosquito, gametocytes, and gametocytes become sporozoites. In man or in human, in the liver, the sporozoites become merozoites. And in RBC, the merozoites forms the new merozoites through stages called trophozoites and schizoids. Pathogenesis is usually 3 factors: cytokine release, multi-organ damage and anemia. Clinical features: incubation period is 10 to 21 days. Characteristic clinical feature is fever with chills, rages and severe sweats. Headache, malaise and vomiting and diarrhea can be there. Falciparum malaria is dangerous. It causes cerebral malaria, black water fever, severe anemia, hemolysis, renal tubular necrosis, hemoglobinuria, uremia, ARDS, hypoglycemia, metabolic acidosis, jaundice, diarrhea, hypotensive shock and hyperpyrexia. How will you diagnose? By Giemsa stain of the blood film and QBC test. Treatment is drug of choice chloroquine. How will you use? 600 mg stat, followed by 300 mg after 6 hours, followed by 300 mg on the second day and 300 mg on the third day. Chloroquine resistant cases, the drug of choice is quinine 600 milligrams 3 times daily for 7 days plus tetracycline 400 milligrams 4 times daily for 7 days. Other drugs we have to keep in mind is mefloquine, arsenate and Malria. Treatment of cerebral malaria, chloroquine 10 mg per kg body weight, intravenous infusion over 8 hours followed by 15 milligrams per kg over 24 hours. Other drug is quinine 20 milligrams per kg intravenously over 4 hours followed by 10 mg per kg over 4 hours for every 8 hours. Prophylaxis, mefloquine 250 mg weekly and chloroquine 300 milligrams weekly. The other measures are using mosquito repellents, mosquito nets. And the last thing is no vaccine for malaria. This is about the disease malaria. Thank you.